Hi, I'm Rick Barron, and Gary Grunseth and I want to welcome you to another session of RAF5. Today we're going to talk about prednisone for myasthenia gravis. There are a number of therapies for myasthenia gravis, and prednisone is really the first immunosuppressive drug treatment for myasthenia. So what is the evidence that prednisone works for myasthenia gravis? I think really the first important paper that came out in this regard was New England Journal of Medicine 1972. Dr. Wormholtz and Dr. Engel gave a report of 5 MG patients that they gave very high-dose prednisone to in a single AM dose of 100 milligrams, and within 24 to 72 hours, all of them improved. This paper had a big impact. The same year, Dr. Jenkins in New York reported a similar experience, very high-dose prednisone. He actually gave it on alternate days. And 7 of 8 patients improved. Now, I found very interesting this old article that I found from Mayo Clinic. Dr. Howard clearly had read those reports, and he and his team attempted to do a small randomized controlled trial of prednisone. 13 patients, half got prednisone, half got placebo, and when he looked at his data, the same number improved in both groups and did not improve. And so he said there was no statistical difference, but he was smart enough to recognize that he thought his study was underpowered. He didn't have enough patients. So most of the large patient experience with prednisone comes from reports of large clinic experience. And the one that I'm most familiar with is Dr. Pascuzzi's and John's from Virginia, when they looked at 116 patients that were put on high-dose prednisone. They actually were one of the early groups to report this prednisone-induced exacerbation in the first week or two in about half the patients. But after that issue, they actually said that 95% of their patients improved, 95% on prednisone, and that the mean time to maximal improvement was 5.5 months. Very interesting, based on the recent thymectomy data that we've talked about. It didn't seem to make a difference if the patient had thymectomy or not with regard to their response to steroids. There were 2 similar large Italian series that basically said the same thing, although in their hands about 70 to 80% responded. The only positive randomized controlled trial of corticosteroids that I could find in the literature is this one by Dr. Lindbergh and his colleagues, in which they randomized 20 patients, either IV methylprednisolone or placebo. They got 2 grams over 2 days, and then they measured outcome with this very sophisticated fatigue metric, and they showed clearly that even with just those 2 days, that the IV methylprednisolone patients did better than the placebo patients. So based on all that, and what I've been doing for years is giving prednisone in roughly 3 different ways. Either the high-dose approach that Dr. Wormholtz first talked about in 1972. I give it daily for a couple weeks, then I switch them over to every other day, and then a slow taper. That usually has to be done in a hospital setting because of the potential for exacerbation. The other approaches are a go low and slow approach that was introduced by Siebold and Drachman in the early 70s, where you give 5 to 10 milligrams a week and gradually build that up weekly to whatever target dose you want. But since the mycophenolate trial came out, which we talked about recently, we know that 20 milligrams a day of prednisone directly out of the gates has a positive effect. And many patients now with generalized myasthenia, I just put on 20 milligrams a day of prednisone and keep them on that dose, and that seems to be effective in my clinic population. So even though we have no randomized trial of prednisone in MG, we really think it works, and we know that there's steroid side effects. They're listed here in this slide. While type 2 muscle atrophy does exist if you want to get a muscle biopsy, which we rarely do, we think that true steroid myopathy is rare, but certainly hypertension, glucose issues, cataracts, and osteoporosis are real, and therefore we have to have concurrent management with vitamin D and calcium. We have to give all of our patients dietary consults. It's usually us, the neurologist, doing it, tell them to do low carbohydrate and low sodium diet. And having said all this, I want Dr. Grunseth to come up and to tell us why is it okay that we can say that prednisone is still the most effective therapy for myasthenia gravis, even though we don't have a large randomized trial to support that? Dr. Gronseth.
Well, thanks, Dr. Barron, for the opportunity to talk about that. So really the question is, when is an observational trial enough? And the short answer is when the effect size is very large, so when the benefit is very large. So if we look at the Pascuzzi study with 116 patients, 80% of the patients had remission or marked improvement, okay, so 80%. So you have to be able to compare that to some kind of control group, and it can be an external control group, but what's the natural history? What would you expect? And so the way to do that would be to like calculate the 95% confidence intervals of that 80% and take the lower number, which is 72%. So that kind of eliminates the random error. You know the study is powered enough. If that 72% is 10 times larger than what the control group, what the natural history is, even with all the potential confounding and such, you can be very confident that there's actually a benefit. If it's 5 times larger, you know, your confidence is less, and you might want an observational study with concurrent controls rather than doing external controls. If it's 2 times larger, an AAN class 2 study is enough to say that it's effective. But and for effect sizes smaller than that, you're going to need a class 1 randomized controlled trial, and the effect sizes in the thymectomy study, for example, were smaller than that, and typically they are. It's unusual to have something as effective as prednisone, but based on that one study, if the natural history is 10 times, you can be confident it works.
Well, thanks, Dr. Gronseth. I knew there was a reason we thought penicillin worked and prednisone worked.
Exactly. You don't always need a randomized controlled trials, but you need a
trial.
large effect.
Right. All right. Well, thanks, Dr. Gronseth.